Welcome to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, "Oh, my vagina."
Yeah.
And
Yes.
that's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it. So, I am sure that you will have all listened to our first episode with Anna Cooper, and she's back! Woo!
If you haven't, go back and listen.
Yeah. Oh my god.
Yeah, please.
So, we had all of the things about getting you back. So the stars have finally aligned. I mean, what happened? A tree fell down, childcare issues, you having major surgery again, then going back into hospital a million times because it really wasn't that straightforward. So all of the things, and it has finally aligned, and we are so glad to have you back.
So happy to have you back.
Thank you for having me.
So, for those of you who don't know, Anna's a massive advocate for all things women's health. She's spoken widely of her suffering with endometriosis in order to empower others. Through her tireless work, she's co-founded the Menstrual Health Project, educating widely and raising awareness for menstrual health-related conditions. Anna really doesn't let living with chronic conditions define her, and is also a wife, a mum to German Shepherds, a rabbit, a tortoise, all of the things. And thanks so much for coming back, because we really felt like we'd just not finished last time, and it was all a bit disappointing. So, and we've had such great feedback from the episode that you did before, because the way you speak is just so matter of fact that it's very empowering for people. And we've discussed this time and time again. You're so courageous, and it comes across in how you speak, and we are very glad that you've made the effort to come back. So thank you so much. So, last time we covered a quick review about endometriosis, your path to diagnosis and navigating all of the surgeries that you've had, fighting with sepsis and against all odds getting pregnant and having little Grace, and adjusting to life with stomas. So today we kind of wanted to pick up, I feel like, oh my god, we covered so much.
We did. Yeah.
We've still got so much more to cover.
I feel like I'm like...
And take a breath.
I think it's quite nice that we're doing 2 episodes, because it would have been one very, very long one, I think, because there's so much to cover with your story and also the whole topic anyway. So it's worked out for the best.
So we'll kind of try and pick up where we left off, if that makes sense.
And we'll just, since it is another episode, we'll do a little recap of just what endometriosis is, just for people listening, in case you haven't listened to the first one. So endometriosis is a chronic, long-term condition. It's a gynecological condition. It's where the endometrium, which is the lining of the womb, tissue like the lining of the womb, grows abnormally outside of the womb. So most often it's in the pelvis, ovaries, on the bowel, and it can be in other areas of the body as well. And it causes a variety of symptoms, but most people will experience pain as the main thing. Also heavy bleeding. It can cause, and that's heavy menstrual bleeding. It can cause some problems with fertility as well. It can cause bowel issues, bladder issues, full body issues. It's not a one size fits all, and it's not a very straightforward condition a lot of the time.
Yeah, not even just that, it's that somebody might have 2 spots of endometriosis and might be really very debilitated by that pain. Other people might come through to have a sterilisation because they've had enough children, and we're like, you've got a frozen pelvis because of endometriosis. And they're like, oh yeah, I did have heavy periods, but nothing much. So the endometriosis that you have doesn't correlate to the symptoms that you have, and that's why that is fundamentally why we don't have good treatments, we don't know how to diagnose it properly, and I think because it's such a spectrum of a disorder that it makes it very, very difficult for us as medical professionals. And I think you face that on numerous bases.
No, defo. So last time we all got together, we sort of talked through your journey from diagnosis way back when, through all the surgeries you'd had, including the formation of 2 stomas.
Yeah.
Since we last spoke, you've had another major surgery. Do you mind filling us in and sort of what happened at that point?
Yeah, it wasn't as straightforward as we wanted it. So I went in to have what was left of my bladder removed, and hopefully that was going to reduce the infections that I was having that was causing me to go septic. And when they went in, I had 2 strangulated ureters, and they had to remove my bladder and fix my ureters and reform the stoma. So I had to have my stoma completely refashioned. So it was a much bigger open surgery than it was meant to be. I had drains coming out everywhere. I think you saw me neck, didn't you? It was not great. And I've got to say, critical care and the team on 5B in the Royal were incredible with me. But unfortunately, I had a post-op collection that just caused havoc, and then I got E. coli again in my kidneys. So I've had 5 admissions since then, and I had my surgery on the 18th of March. So it's just been back and forth. And then not the last time, the time before, I had a PICC line put in permanently for now because my veins just started to give up. And yeah, so we're going through the motions at the minute. The surgery was to hopefully reduce the infections, but we knew the risk was actually that it might take away some of the pain that I was getting and the bleeding urethral, which it has. But it hasn't taken away the infections, and that's something no one at the moment knows why is happening, so we just have to go from there really and take it day by day.
Actually, and I just had my bladder removed. So just a quick recap there. So the ureters were strangled. So ureters is the tube that goes from your kidney to your bladder, so this transfers the urine so that it can come out of your bladder. We know that actually doesn't happen with you because you have a stoma to collect the urine rather than it coming out of your urethra, which is the tube that goes from your bladder to your outside so that you can pass urine, but you're having bleeding from the urethra, the tube from the bladder to the outside, which we're hoping might be a little bit better now that you've had the bladder
completely stopped now.
Oh, fantastic. Bladder removed. But it just like, again, we go back to this, like, we have bladder removed, ureter strangled, stoma refashioning, had sausage and mash for tea, then watch Neighbours.
Bed by 11.
Like, it just...
Yeah, like you clearly take it all in your stride to even just sort of like reel that off in such an eloquent way. And also, I mean, just is an example as well of how much of an expert patient you are. Like, you could just be one of the doctors sitting there and telling us about another patient, the way you've described what you've been through.
Do you know, the amount of times one of my consultants said, have you considered going back and go and train as a doctor? I was like, I spend my life in hospitals.
Yeah, I couldn't think of anything worse.
I can't do that. But I think that's probably why I'm so passionate about talking about it, is just to normalise that conversation around it. And yes, it's not great, and it's that extreme end of what the disease can do, but also, like I've said before, I've got no choice, so I have to kind of take it in my stride. And believe me, while I was in hospital, it was not easy, because being away from Grace and my husband, we're not down the road because we're over an hour away, and it was tricky, and we're still in the unknown at the minute, but I think that's the biggest lesson endometriosis has taught me, is it's not just the disease that kind of impacts you, it's what comes after and what the kind of domino effect it can have on other parts of your life and other parts of your body. So it's more about the damage of what it's done now rather than the disease itself. And I think that's what's so important for people to understand, is that it's not endometriosis causing that havoc anymore. It's the kind of aftermath of what's happened, and that's why I lost kind of my large bowel, because endometriosis had ate into it. It's the only way my consultant described it, is like it's like, you know, a tree root, and it just rooted into the organ, and then it destroys the function of it, and then your muscle function and your nervous system's not working the same, and that's how I lost it. So I think for me, I've got to be matter of fact in the way of looking at it, because otherwise I'd be way too emotional, and that's okay being way too emotional, but I think for me to live with it logically, I have to see it the way it is, and don't get me wrong, I have my bad days, I really do, and especially the last kind of however many months since March, it's been hard, and you're kind of living on the edge a little bit. And I said this to Nick all the time, it's waiting for that next blood test that's going to tell me whether or not I need to go back into hospital. And I could be feeling relatively fine, you know, I could be feeling like I am now, where I feel strong enough to be able to drive and, you know, get out the house and do things, but then my bloods are telling me a different story, and then I'm being pulled into hospital. So yeah, it's tricky, but it's what I've been dealt.
Well, thank you so much for coming back on, because you know, you've been in and out of hospital, your time is precious, and you're choosing to spend some of that with us here. So we appreciate that a lot. And also I just really wanted to say that, so, you know, for you to be the expert patient that you are, you've had to go through all of these difficult things, but as you were just saying, you're turning it into a positive in some ways, because you're sharing this journey with people who'll be listening who may have endometriosis, and hopefully equipping them with your experience to try and prevent potentially them going down a route that might lead them into complications if they don't need it. Surgery is important and it's necessary, and it has its place, but it's not the be all and end all, and there are complications that can ensue afterwards. So sharing your experience so candidly is like really
empowering.
But also to
empowering.
empower those people who are struggling in similar situations to you as well.
I think that's my biggest thing, is a lot of the time if people hear my story, it can become quite scary, you know, especially for somebody who may have been diagnosed with bowel endometriosis or bladder endometriosis or whatever it may be. But my thing is to really kind of make sure that it's a collective decision between you and your medical team of what's best for you. You know your body, and speak up on that. I think that's really important. For me, I wasn't aware of what endometriosis could do. It wasn't spoken about back when I was younger. It's spoken about a lot more than it was. It's in the media all the time now. Whereas, you know, I think it's making sure that people are aware of the risks. But it's also, like you said earlier, it doesn't mean necessarily if you have bowel endometriosis you're going to end up with a stoma, and the same. It's just, the way I see it is, it's just been bad luck with me, and I think we've just got there a little bit too late every time. And you can go through life blaming previous situations with medical professionals, but for me, what I've learned, especially through co-founding Menstrual Health Project, was, you know, not every medical professional gets the education that they need on this condition. So instead of getting angry, for me, I'd rather use my voice in a more positive way than a more kind of, which is just frustrating.
And you do a great job doing
that. I think, you know, when you such succinctly spoke about what happened when you had your surgery just then, I kind of think that is, and I'm slightly going to digress, but because Anna is so young and she's on ITU, and in a way people are really unexpected of someone like Anna to be on ITU, so it was that kind of difficult situation whereby people were like, I'm sorry, why are you here? So I feel like ITU? So like intensive care unit, and she's kind of having to like justify why you're there in a way. So to be able to say all those things that happened was something that probably need to roll off your tongue for the people that weren't there every day and didn't know your story and weren't aware of your background, because, you know, not the same person works every single day of the year. So you're left like having to explain yourself to the new person that's coming to see you that day. So I think that's why you're able to do it so kind of succinctly, because you've probably had to kind of, as a medical student would, give a history to somebody. Because I really think that it is outside of the norm of what people would usually see, and people don't expect you to be there with that kind of history. And it's sad in a way that you have to be able to be like, this is what happened and this is where it's going and this. But in another way, it's actually very empowering that you can do that, because it means that you can speak and say, look, this is what's happened. This is why I'm here. Full stop. The end. No further questions needed. Mic drop.
I think it is really difficult in a sense of when you're in a situation like ITU, I was on so much medication that you forget half of the stuff that you need to say sometimes, and that's why like I was very grateful that I had my husband most of the time, or my cousin or my best friend was there, who could say things. But majority of the doctors who weren't my consultant or my team, they presumed I'd had cancer or some form of cancer, because really in the way they said it, it's like you've had pelvic exoneration surgery because you've had so much removed.
Like there is nothing left that is not essential.
And they didn't quite understand until I said it, and you could see the cogs working. And it's rare, like, to see it that. And as much as I know quite a lot of people in similar situations, I still don't really come across many people with 2 stomas my age for the same reason. So it is really difficult. And but I have to say, like, shout out to one of the nurses in ITU, because when I left ITU and I got stepped down to the normal ward, because he made the best cup of tea. He would bring it down to me for 7 o'clock in the morning at the end of his shift. And like I can't thank them enough, and they were incredible. But it was things like the frustrating part with remembering all of the stuff that you've been through. I think the biggest frustration that I've come across was definitely having to have CT scans, because they forced me to do a pregnancy test, and even though I'd had a hysterectomy when I was 28, so I had to do a
Where would that baby
test.
be growing?
So even though they could see it on my notes that I've had a total hysterectomy, have everything removed, CT wouldn't accept my request without me proving I wasn't pregnant.
That's a frustration, isn't it?
And to me, it's a waste of money as well for them.
And time.
But just a useless step. Like, why?
Surely hysterectomy is a better negative pregnancy test than a negative pregnancy test.
But also
use some common sense.
Yeah, exactly. For me, I get it. There is politics around it as well, but also use common sense. It's on the notes, but also the trigger that can give to a patient. Like, I've done a lot of work through the years, but secondary infertility is not easy. You know, there's people having babies at my age now, so then to be forced to do something when you had to have it taken away from you early because of your condition, I think things like that really need work.
Definitely. Like, that's a really good example of, so that can cause harm to patients like yourself, but the reason it'll be in place, it'll just be a blanket rule so that no one gets through without a pregnancy test, just in case someone does, because obviously the negative, if you've got someone that comes through pregnant who has a CT scan, the fetus is exposed to radiation, then we don't want that.
No.
But it doesn't mean that one blanket rule has to apply. Like, you can use some common sense and think about patients that it might harm. And that should... that's just after. I mean,
Haven't really got it.
frustrating.
I think the problem is you were in hospital so many times and for such a length of time that nothing is ever going to go completely right. Like, because it can't, because working is different Saturdays and Sundays, working's different on a whatever, working's different on that ward. Like, not everything's going to go right, and it's frustrating. And I, especially as a clinician, find it so difficult. And I know we had these conversations because I'm just like, but I just want it to go right for everybody. And it's
frustrating.
It is really difficult when you're looking and thinking, okay, so got the PICC line yet? And like,
Yeah.
because I can't do anything about it. I don't work there. I'm not part of the like putting PICC line team in at the like. I don't have anything to do with that. But it's frustrating.
Realise as well, when you were talking at the beginning, we've mentioned what ureters are. You mentioned a pelvic collection. We should probably just say what that is. So, a collection of fluid around, well, in your case, it would have been pelvis or abdomen, and that can become infected. So after you've had surgery, if you get that collection of fluid that becomes infected, it can make your stay longer. You might need antibiotics. And then a PICC line, you mentioned as well. Lots of people might not know what a PICC line is.
In my arm.
It's a peripherally inserted central line. It's a line that goes into a central vein, but from your arm usually, which means
And
you
is
have
that so
access.
like treatment and stuff
Like
going
antibiotics
quicker?
and
And you can have blood taken from it.
Okay.
Yeah.
Which is a game changer.
It is a game changer for me, definitely. I think so. It goes up into your arm and then down and into your main artery above your heart. So, and that was a game changer for me. But again, there was a lot of politics to get that done because my local hospital is the one that have obviously done a lot of the IV antibiotics, but because that's Wales, they don't. Liverpool didn't have access to that notes, so they didn't see how many times I'd had been administered antibiotics. They didn't see how many times I'd gone to theatre for midlines, and it was basically lack of communication between the trust and the health board in Wales. So the microbiology in Liverpool were saying she doesn't need a PICC line because this is just one-off infection, whereas my urology team were going, no, she's had loads of infections. So it basically all it was a phone call, so they could send over the details, and then that was done. But it was like 2 days by the time we got rid
but
of it.
wasn't it then like
Another
was it
hurdle.
the bank holiday?
It
and
was,
then it
yeah.
was I felt like it was just one of those things that I was like, oh my god.
Yeah, and then they were in my feet, and it was really bad because my veins had kind of given up, and when that treatment is keeping you alive, quite literally, because so you don't go septic, is. For me, it was just frustrating. I was like, just put it in because it just makes
But
sense.
the solution is there, just do it, you know.
But because they didn't have the paperwork to back it up, even though my consultant knew, it just wasn't on the system. So
It wasn't like an 2 + 2 = 4 situation.
Yeah.
It was
No,
like, let's
it
go around
was
the
so
houses
much
to get back
worse.
to another 4.
yeah,
But I hasten to add, it wasn't all doom and gloom in the hospital because
No.
there were some days that you definitely did not look unwell, but there were other days that she was shiny, but like she got all the skincare, she got all the everything all sorted.
yeah.
So,
That's one thing
Got to do what you can, haven't you?
if I'm in hospital for a long time, I will make sure my skincare is there, my whole step routine, and my LED mask. So I'll have my LED
We
mask.
exchanged LED picture.
Oh, did you?
The amount of times I scared the nurses when they came in to give me treatment.
Is it one of the big white?
Yeah,
ones?
that goes red, and then it changes.
Look a bit like
to,
Darth Vader.
Yeah, changes to purple, and then yellow, and then pink. I think.
the rainbow.
It does different colours for different kind of skin, and I was like, for me, that's my kind of bit of routine from home to keep me kind of straight, because I really struggled this time around because Grace is of an age where she is frustrated at the fact she doesn't quite understand why they can't fix mummy, and is feeling all the feelings as a preteen will, and I think there was days she didn't want to come because she just didn't want to see how ill I was, which then in turn made me upset. She wasn't intentionally upsetting me, but it was like that, a kind of frustration and anger that it gets in the way of everyone's life, not just mine. And so for me, I will hold on to kind of small things, like even if it's just my skincare routine,
that makes
or
sense,
you know, FaceTimes every morning, and make sure I've got the best pajamas on the wall. I will
She
make
was
sure.
definitely best pajamas.
Yeah, if anyone knows me, they know my pajama collection
Best
is
dressed
nearing
pyjamas,
about 50
honest.
And where would you say is
Wow.
the best place to get your pyjamas?
So I have my list. So if you want to go bougie, I'd say Chelsea Piers all the way. And if you want your like day-to-day pajamas, the lightweight Sainsbury's. 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 And then like middle of the line, I'd say Next.
I knew Next was going to be
Next is going to be
I was like,
there.
where's Next in this?
But Next, for me, the only problem is with Next is they sometimes their length for regular isn't long enough, and then their tall is too long to me.
When
So-
you're in between,
Yeah.
alright with
Yeah,
small.
so sometimes, so I'm still waiting for Next to listen to me, to be honest.
We'll get there.
Yeah, but yeah, like for things like that, that's where I take comfort from.
Yeah.
It is the little things, and yeah, if that makes sure that I've got the best pajamas on the ward, then I will.
She definitely
100%.
And like matching case and matching like all
Yeah, one of my doctors walked in and was like, does somebody like leopard print in here? And I was like, well, of course. Like, leopard print blanket, leopard print case, leopard print like laptop case, like,
oh no,
everything.
definitely not me.
So we've discussed all about all the different things with endometriosis. You also have a diagnosis of fibromyalgia.
I do.
Yeah, I don't think we covered this last time. I also don't think we've particularly covered fibromyalgia.
No, we
haven't.
at
Which we should
all.
really, because it's more common in women than men, and it does actually go hand in hand with a lot of patients who have chronic conditions like endometriosis also have fibromyalgia. So we see it a lot, don't we, really?
So if you wouldn't mind, if you could give us a little run through about what fibromyalgia actually is, and and
How's it
your
affect
experience
me?
has been. Yeah.
To be honest, it came as a bit of a shock, to be honest. I was diagnosed with it, it'd probably be 2 years next month, actually, and I got referred to rheumatology in Aintree because I was getting all these weird symptoms, like I'd feel like my bones are on fire, my hands would swell, you know, like feet would be like burning, itching, I'd get really bad joint pain, nerve pain. I've always had nerve pain ever since I would probably say my 19 surgeries now. So I'd say after my first resection, I started getting quite bad nerve pain, you know, so from lower back down my thighs where it burns, and I've always kind of put it down to just scar tissue or just aftermath of surgery. And I got referred to rheumatology, and I remember sitting down. I was really nervous because, again, it was a new consultant, and I remember sitting down with her, and she went through everything. And she said, right, we're going to do all these tests. And it was about 5 different... One of them was a load of blood tests, and the other 4 were loads of different types of scans, X-rays, MRIs. And I said, well, we're going to do all of the tests. And she said, yeah, if we don't do all of them, we won't know the answers. And I was just baffled. Like, I was like, wow, this is amazing. Like, get it all done. And I had it all done. And that's when we found that I had borderline osteoporosis in my hips and my lower spine. So from my bone density was really low. So I'm actually due DEXA next month to see if it's got worse.
DEXA, the bone scan?
Yeah, bone scan. And they said that was due to I wasn't absorbing my estrogen. But then they'd put all with my pain consultant in the Walton, they'd put all my kind of pain symptoms all together with the results of my scan, and then they diagnosed me with fibromyalgia and said it was really common with what I'd been through because I've had so many surgeries that it was kind of inevitable that I was going to have it. And they explained it as if neuropathically that your brain and the pain's not working the same. And for me, to be honest, and I don't really talk about it a huge amount, mainly because it's another thing added to my list, and I find it tricky when it's the same with when I was diagnosed with osteopenia. It's one more thing to think about. So I was kind of trying to, go through life and not worry about it. But I do definitely notice things like heat, weather affects it. So like the heat that we've just had, like the really boiling heat, is the pain that gives me all in my bones, like my whole hand kind of just clam up where I can't lift a mug, or my hips just feel like they're grinding constantly. And the nerve pain as if you can't get comfortable. So the irony of being in a heat wave, having a heat pad on, and then having your aircon unit on your face. You're trying to cool down because you're menopausal, but equally you're trying to put heat on the pain that's shooting down from your back into your legs. And it's something that just is managed with my pain management team, with pain relief. They wanted to put me on a pain management program, but it had to be stable from infection, and we're not there yet. So we've been trying for 2 years. So we're not there yet, but something that I do try and do is to keep moving when I can. I take things like gabapentin to help with the neuropathic pain. And on fentanyl patch for pain relief as well. The issue I have is because I've lost half of my small bowel, I've lost all my large bowel, I've got a really fast transit time, so trying to get medication to absorb with me is really difficult. So and it seems like even skin absorption with HRT isn't working either. So I think they all play into one at the minute. It's really hard to differentiate between what is fibromyalgia and what is the osteopenia, what is just post-surgery issues, what is endometriosis. It is really difficult, and even my consultants say that we kind of have to look at it as a whole at the minute, because one symptom could be causing one and the other could be causing another, and it's very different. But I definitely notice the biggest thing I would say is the burning of your joints that you feel. And it's just a really difficult one to manage. Like, so people get so many different symptoms from it.
A bit like endometriosis in a sense.
Massively. And I think, again, the one thing I've noticed is there are a lot of doctors who don't believe in it.
There's a big stigma, isn't there?
Yeah, massive stigma.
And I think, again, it comes from a lack of education. And just a lack of understanding of the condition. It's one of those conditions, because there's no test to say you've got this. You can do all of the tests to check it's not something else which you have. But because there isn't a test to say, yes, this is definitely it, and there's no definite known cause, it's like one of those things that's caused by probably a bit of a genetic thing. There's a big association with someone who's had multiple surgeries or long-term infection or other kind of trauma. It's hard. It's not hard to see it, but they just don't get the right kind of spotlight when it comes to a sexy disease like high blood pressure, which you can see and measure. Everyone's like, okay, cool, and have this tablet and your blood pressure comes down.
That's so fun. I've never sexy diseases. It's like when they did I don't know if you've seen the research they did on endometriosis. Apparently better looking women.
Oh my god, yeah.
And I was like, are we actually researching that and not the other thing? But no, I think
terrible.
It's, for me, I remember when I was being diagnosed with it, it was an elimination of things. So they wanted to make sure I didn't have rheumatoid arthritis, lupus, things like that. And then they basically had like a tick box of what I needed to suffer from to then be classed as
Yeah, yeah,
fibromyalgia.
Yeah.
And
It's like if you have this, and this,
Like a
then it will
question.
be fibromyalgia. If it's not one of the other things.
Yeah.
And obviously you don't want to have rheumatoid arthritis, but in a sense it's sexy like blood pressure because we know that we can give another treatment, and rheumatoid arthritis would not be cured, but it would be treated by that.
it's
kind of
really
similar in some
difficult
ways,
to
sorry.
manage.
Yeah. With endometriosis and fibromyalgia, they're both not well understood in terms of what causes them. The treatment is difficult, it doesn't work for everyone, and there's also a spectrum of patients, like how it's affecting you. Not everyone will have the same experience of the same disease. So they're just more difficult, aren't they? They're a challenge.
And it's like the symptom
hard
management. I think
sometimes.
people find it very difficult to get their head around that if you have symptom X, then you should try these things here. Whereas people are like, yeah, but I want you to treat the condition. I don't want to mask it with a treatment. And you're like, no, you're not masking it. We're treating the symptoms. And it's that kind of open conversation about trying to make your life the best it can be, the best, like you are living the best version of yourself, and that's by treating the symptoms that are affecting you. We're potentially not treating the disease, we're treating the symptoms,
how it actually manifests in you.
And I think people find that difficult.
I think you can't get rid of it, can you? That's the problem. And I think that a lot of people, including myself, you want to get rid of it. You don't want something else on your list. And it is really difficult. I think people don't understand it. They don't really know why it's happened. I was just explained, the way it was explained to me was because I'd had sepsis so many times, had surgery so much, suffered with chronic infections, that my body's just in fight or flight and it doesn't know what to do. And that's why I'm getting all this kind of pain down my legs and everything. So they said it was kind of inevitable that was going to happen. And same with my bone density, really, that it was the same issue because I had my ovaries removed at 28 and then I didn't have my estrogen monitored. It was kind of a few years later they were like, oh, your estrogen's on the floor, even though you're on the highest dose of estrogen. So, but then because I was just borderline, so I was the worst level of osteopenia, but borderline osteoporosis. They don't give you the bone kind of protection therapy because you need to hit osteoporosis before you qualify for those. And I get it because of you run out of treatment options if you try too early, but then equally it's a bit like, well, you've got to get worse before you can even try anything. So you're just waiting, really. So
This is all related to premature ovarian insufficiency.
Yeah.
So because you had not just your womb removed, you had your ovaries removed as well at the same time, then you are at that point straight away in a surgical menopause, which is people describe it as like night and day, because when you are menopausal, and there's loads of chat these days about that you're perimenopausal, then your periods might become irregular, then your periods stop, then you transition and you're menopausal, and you have this kind of like transition time in a sense,
which can take like several years. It's not just a couple of days or overnight.
Whereas Anna will have been on Monday not menopausal and on Tuesday menopausal, which is a massive shock to the system. And then it's so important, because you were so young, that you have estrogen, because estrogen is longevity for a woman. So we know that if you don't have the estrogen, then you basically decrease your lifespan. You are then more at risk of having brain conditions, of having heart conditions, because basically you are menopausal. So instead of being 28, you are 55, you're 60, you're 65. So therefore you are at risk of having problems with your bones. And that's what Anna's been talking about with the osteoporosis, osteopenia, that the bones are not as good as they should be, because they haven't had the estrogen for long enough. Because when you're in your 20s and your 30s, you're making your bones as strong as they can be, you're eating well, you're making sure that you're doing your exercise, and then that's making your bones super, 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 super strong, because then when you become menopausal and your estrogen decreases, your bones are just going to get worse from that point, basically. And that's why it's really important that people do strength exercise when they are menopausal, and we've had a chat about this before. And before. But,
All the time.
all the time. But looking after bones, cardiovascular system, so your heart, your brain, all of these things with estrogen is very important when you're so young, but also really difficult in yourself because you won't absorb orally because you've lost most of your bowel. You're not absorbing through your skin, is what you've just said as well. And also we know that estrogen feeds endometriosis, so obviously you've had all of the internal organs removed that you can do with regards to endometriosis, but if there is any endometriosis that could grow when we're giving you estrogen, then there's a chance that endometriosis could come back as well. So it's a really very difficult balancing act, I would imagine.
Yeah, it's really difficult. I think I'm under, which I always find hilarious, is geriatric medicine now, and my consultant there, it will test, which I fought for years after my hysterectomy to get my estrogen checked, because I knew I wasn't feeling okay. I was like, I'm not absorbing it, I can guarantee. We tried the patches, we tried the gel, and now I'm on Lenzetto spray, and that seems to be the better one of all of them. But no one would test my estrogen. My GP wouldn't test it. My gynae wouldn't test it. My gynae just said, just up your gel. So instead of 4 pumps, go to 6 pumps. And I was like, well,
that's a lot of pumps.
If it's not
It sounds like a lot,
That's a lot of pumps, guys, but also, like, so it's way off guidelines with pumps, but also, where on earth are you going to put all that gel?
I know, I know.
The whole
if
body.
anyone's felt it, it's like glue, like it's awful, and you put it on your inner thighs,
so
and you're walking around like trying to let it dry.
So
It's just
two
not-
pumps, like, very straightforward, can get in.
Yeah.
But if you're talking about 6 pumps, like,
It's
how
not.
is
It's
that
not
ever
the
gonna
best at all.
And also you can't, and
it's
also
still gonna-
you don't want that to go on your partner because it's transferring estrogen. You don't want that to go on your child, it's transferring estrogen. So
your
you then
animals.
can't be like,
Or your German Shepherds.
you can't be like drying yourself in a towel and then someone else is using the towel. So like if you've got
just
all
not
this
an
flipping
ideal
gel everywhere,
treatment.
like that's not an ideal situation.
No.
I just want so that people get that, because
Don't just up to 6.
people might just
No.
be like, oh, it's just a gel, it's not a problem, but
But it is.
It's a big
that's
volume
a
of gel.
lot of gel.
Of a very gloopy gel.
Yeah.
It is. And it's not, it's like, the only way I can describe it, it's like the gel, you know, they put on ultrasound.
Yes.
That's how, that's the
lubricant.
consistency. Yeah. So, and for me, what really frustrated me about that is the fact that my levels were really low. So when I'd had my first estrogen test, I think they were 82, and they should have been on, the amount of gel I was on should have been in the 400s.
Yeah, I was going to say hundreds, definitely.
The fact that they then said, "Oh, just up it by another 2 pumps," well, it wasn't going to do anything because I wasn't absorbing it in the first place. So for me, it was really frustrating. So so then we decided to change to Lenzetto. Thankfully, through the charity I work with some really amazing menopause GPs. So she suggested going to the spray, so I spoke to my GP and she agreed. And again, I think this is why I think it's vital that there should be a menopause specialist GP, or at least a women's health specialist GP in every practice, because I know I'm asking for a lot here with with everything going on, but I do think it's vital, especially how much of the population we are, because things like this aren't just, it's not just an anomaly with me going through it. There'll be so many women going through it. And so we did the Lenzetto, and that's 4 sprays, and much easier. It dries very quickly.
Less gloopy.
Yeah, so it literally, you spray it and then it dries almost straight away. But then I went back and had it retested, and it only had increased to 94. So still, again, way too low for what it should be. I can't take any estrogen orally. Vaginally, they were saying, like, I was already on Vagifem, so the pessaries, I was on the gel, as in the like cream, topical cream down there as well. I've got vaginal atrophy after having it. There's just so much they don't tell you going into a hysterectomy. I think the aftermath that I was so shocked at, that I didn't know. And I think going into it so young as well, you're really naive in the sense of you feel like they would prepare you for what's coming after, and they didn't. And I think I had to navigate that myself, and I'm not the only one. There's so many of us out there that have to do that, and I just find that baffling, because you're going to cost the NHS that much more money in the long run. And like now, they said with me being borderline osteoporosis, I'm going to hit osteoporosis now. So whether this DEXA next month will show it, we don't know. And I think for me, that's my biggest fear, is kind of my bones starting to be affected, because it's not just kind of organs then, but bones scare me more than organs. You can take my organs, but my bones, I don't want like hip replacements and things like that. And you know, like, there's genetic heart conditions in my family already, so making sure my heart's healthy is top priority for me. And if you haven't got the estrogen to protect that, you're kind of at a loss. And I don't think that's taught enough, that estrogen, how much it protects.
It's so important, like
so important.
Genuinely so important. And I think we can talk about how important it is from bones, heart, brain, all this kind of stuff. But from you just touched then on vaginal vulval atrophy. And this is something to just be like a normal prescription if somebody's leaving hospital and they've had their ovaries removed. Like, you're going to get this. I'm sorry, but urogenital atrophy is coming your way. Use this. Because actually...
I was just going to ask, is that where it's really sore?
Yeah.
So, you know, it's quite common in postmenopause. So the like vulval vaginal skin has lots of receptors for estrogen. So estrogen then makes it more kind of like younger, healthy, plump kind of skin. When you go through the menopause and there's no estrogen, it just becomes drier, thinner, more likely to sort of tear. It can be more painful.
Lose structure.
Yeah. You can lose the vulval
like the
structure.
architecture.
But
you want to
can
use
have it at any
it
age if you don't have estrogen.
before you get to that, because actually that will be much better. So if you can preempt it rather than wait till you've lost architecture and it's really sore and you can't wear knickers and you can't, like, all this kind of stuff, you don't want to get to that. You want to use it before so that you've got kind of, you're up and running and ready. But people don't talk about it. It's not out there. It's not sexy medicine.
Bizarre,
it is.
You know, like someone having a hysterectomy, removing their ovaries, and they're premenopausal. Like, obviously, this is going to impact things like the vulval skin, the vaginal skin, sex life, your longevity, the cardiovascular risk, osteoporosis. These are conversations that absolutely should happen before that consent form is signed. And it's crazy that they're not. It wouldn't, it's
but
just...
I think it's from both sides. So, like, I definitely should happen when somebody's consenting and people need to know. But I think people do go into it from the flip side of this, that I can have this conversation and be like, when I remove your ovaries, you will be menopausal. This is what will happen. And I really try to make sure that people are aware. But I really know that they're going to be like, I wasn't aware of that afterwards, even though I know that I've gone through it, and I'm like, you need to be aware, you need to be aware, you need to be aware. Because people listen sometimes to just what they hear, what they want to hear.
I think it's tricky, isn't it, when someone's in pain and they see a treatment as that will improve my pain,
resolve everything,
then you can't sometimes see past that and think about the potential downside, because you just, in that situation, all you want is the pain to be gone. Whereas then when you're past it and maybe the pain's gone, maybe it's not, then the realities are different. You're able to see it a little bit more.
I think
it's hard. Yeah.
It's desperation a lot of the time with going into surgeries like that, is that you just want the pain to be gone. So sometimes you don't take in the information, but then there's definitely the other side of it's not spoken about at all.
I'm definitely not putting that on a patient, but I'm putting that on like it has to be that there is understanding throughout.
Definitely. I think that's why kind of patient and professional collaboration is absolute key with surgeries. It was the same with my stoma, with my ileostomy. I wasn't told the risks of what would happen with like the nutritional deficiencies and things like that. None of that. I learned that afterwards, and I think it's stuff that seems so minor but actually has a huge impact. Like vaginal atrophy for me, like not to be kind of TMI, but last week in the heat is I'm there icing myself down there because it's so burnt. Like, not that I've been in the sun in it. It's just that you're wearing clothes and it's so sore that you can't wear jeans or you can't wear certain underwear. Everything has to be cotton. You can't wear like you can't use certain products down there. Not that you should be anyway, but if shower gel accidentally gets down there, it's even worse. But it literally, it's a bit like the way it kind of reminds me of is a little bit like fissures, that you get rectally, but it's on your vulva, and it's so sore, and like you said, it affects your sex life and it affects everything, but you're not warned about it at all, and
you're thinking all the time, because you're thinking, well, I can't wear that outfit, I can't sit on that, I can't be doing that for that long, I can't it's like a thinking all the time situation that it's definitely not ideal at all.
No, and I think you then, part of you's going, is this what I have to deal with for the rest of my life? Like, and it's a lot. Exactly. And I think it is, and it seems for a lot of people sometimes it seems so minor because obviously it's taken away pain from another aspect, but actually symptoms like that can control your life because it impacts you. Also really impacts your mood. Like it can make you in a crank. Like ask my husband.
Fair play.
Because you're sore and
if you can't get comfy.
Well, this is it.
It's a bit like that.
And you're hot and bothered and you're getting hot flushes anyway, and it's just there's a lot. So I think that's one I would definitely say, something that is never really spoken about. And even when I speak to my GPs about it, it's like, oh, just put lidocaine, you'll be all right, and stuff like that. And it's just, but lidocaine burns when you put it on. So yes, it numbs afterwards, but it does burn, and then. And
it's more gel.
It's more gel, and half an hour later, it's you're back to being sore again. So I think it's
and
I've
it's
tried
like
yoga
numbing.
before.
It's not like it's not.
It's
like,
still not making you feel comfortable.
No,
it's weirdly
it's not.
If you can imagine, the way I describe it to people that don't go through it, it's a bit like if you've ever had thrush. It's a bit like that.
Like irritated all the time.
But it's the soreness and the pain that you get rather than the itchiness. And you just feel like you don't want to go anywhere when it hurts. It's fun being a woman. Really.
It's really fun. But I do think it gives people something to think about, because we need to kind of think about best options, not like one option fits all, because it doesn't. And you, like, by speaking like this, are telling people that there's a flip side to everything that you do. And I'm not saying that it should stop people having their ovaries removed if they need their ovaries removed, but also remember that if you're having your ovaries removed, these things will happen. It's not like they might happen, they will happen. You will have these sequelae because you will have no estrogen. So it's not like it might not happen to me. That isn't in this case for once, actually. It will happen to you because you will have no estrogen. So it's just something for, I think, people and everybody to be very aware of.
I think as well it's making sure people feel that they can ask the questions, and that's okay. You know, that these things are such taboo subjects. I think especially talking about vaginal atrophy, like that was never really spoken about, and still, even speaking to my GP, I don't think there's really that kind of understanding of how it impacts someone day to day. But it's just making sure that they're aware of it, that they've got the information around it, and like you said, being sent home with that estrogen cream.
Like, this is what you need to do.
Yeah, and like
wait.
you know, like the estrogen pessaries that they give you, that you take every day for 2 weeks, and then twice a week after that. I take them every single day because my estrogen's so low. So it's things like that there are things there that can help you, and absolutely talk about it. But it's more of a even intimate subject than talking about things like endometriosis, and so people find it hard to open up with it, and also know if it's normal or not when it comes to menopause, because we kind of, there's so many different symptoms that you can get with lack of estrogen that we kind of forget about that one, definitely.
Yeah, no, I agree. I feel like we have to touch on this, and it's kind of difficult from, I suppose, my side as a medical professional, because I've told you before that I really hate it when people don't get great care, and whether that's family, friend, all that kind of stuff. I just, it really like, it makes me feel really awkward, because I am very much NHS, and I, you know, like really I am NHS.
Which everyone should be.
But you've spoken quite openly about medical gaslighting, and so I think we need to look up this, like, how as medical professionals can we be better? How can we educate others? Just like, obviously we don't have to talk about this for forever, but I do think that we can't not talk about it, because it looks like that we're shying away, and we're not shying away from this, because I know it happens. But let's hand it over to you. How can we be better?
Well, I think you're all doing a very good job. But let's go back and take my first consultant as an example, because I was gaslit horrifically to the point that I was told I needed clinical psychological help, because she thought my pain was all in my head. And then that kind of had a ripple effect, because that then was put in writing. My GP then didn't believe me, and it was kind of this just back and forth. And I mentioned on the last podcast, you know, I was diagnosed through having my appendix out as an emergency, and I'm very thankful to that general surgeon for even knowing what it was. But I think the biggest thing you can do is listen to a patient and try and understand where they're coming from, in a sense of, a lot of these people have lived in pain for years and maybe sat in silence and not really known how to advocate for themselves. Not jumping to assumptions, I think that is a huge one for me. I've had it even since I've been married, you know, when before I had my hysterectomy, where they said, oh, well, you know, could it be a sexually transmitted disease? And I'm like, well, no, because I'm diagnosed with endometriosis and I've been tested before. And they said, but how do you know that your husband's faithful? And I was like,
what question?
This feels like a big jump.
And it was things like that, you know, that there's such a lack of
not
care.
a throwaway comment.
There's just no need to say that. And I think there does come an ego with some consultants. I've definitely had it where, you know, like I've had one consultant say to me, if I was a horse, they'd have put me down by now.
Oh, great.
Oh, wow.
I had another consultant not long ago actually say to me that I don't know why I keep expecting them to come up with answers about my sepsis, like the repeating having sepsis with my urostomy, because one day it'll kill me, and that I just need to get that in my head. That was in front of my husband.
Oh my God.
I was 32, sat down thinking I was going to die, so that was great. I think it's the way things are articulated to patients. I think it's having that compassion and that care. I've met like yourselves, incredible medical professionals that you can just see that are aware. I've worked with them with Menstrual Health Project. We've got some incredible medical professionals that really are there to kind of change the preface on women's health and really change that narrative of that women are going to be gaslit straight away and want to kind of change that example, because unfortunately the statistics don't lie that, you know, women are gaslit and ignored. A lot of the time the research isn't there to help us. The funding's not there to help us either. Massively. Yeah, I think, like, I've been in the rooms with, you know, Gabs, my co-founder with Menstrual Health Project. We've been in those rooms with funding being discussed, and women's health is always like the bottom of the pile, and we're always trying to fight for better improvement. But I think it's got to be a collaborative approach, but ultimately it's compassion and really wanting to listen to your patient and hear them out and not cut across them. I've had that a lot where, you know, you kind of try to get schooled about how you live your life, and it's like, well, actually I'm living it day to day. You're the medical professional. I completely kind of appreciate that, and I will always respect that, but you've also got to respect that this is what I'm living and this is how I'm experiencing it. And I'm very lucky that I've got an incredible team now that are really understanding, but it's when you come across, you know, medical professionals in between who don't really know your care. Hence what happened when someone was trying to tell me I was going to die, you know, in the next few years, which is not what you want to hear. And it's things like, you know, after having Grace prematurely and the pregnancy not being straightforward and things like that, they were saying, I had one very lovely midwife saying, oh, you know, well, you've had one now, you can have another one straight after, and you just need to get on with it. And kind of it's just the way things are said and kind of put across. And I think medical professionals get a really bad rap because of the people who are letting you down. And we always hear the bad, not the good, and I think that's what we've tried to change with MHP, is that we share the good stories rather than the negatives. But there are such a staggering amount of women who've had such negative experiences, and it could be, you know, from primary care right through to tertiary care, or it could just be, you know, a physio, or it could be, you know, whatever it may be. There's some story in there somewhere where they felt like they've been put down. So I think it's we need to just, as a country, I think, give women more understanding, and funding would be great.
They're all on board with
everyone will say that. And like you said, the NHS is such an incredible you know, incredible establishment. It's just unfortunate the pressures that we're now under. My mum worked as a mental health nurse for 40 years, so massive advocate for NHS, and, you know, without them I probably wouldn't be here today, because we've been close calls many times. But I think they also have to understand that women's healthcare needs to be a priority, and it needs to not be just let's talk about it on, you know, on BBC News or ITV or whatever it is, and say we're doing something and it not actually coming through.
Do something about it.
We've seen it, you know, I've been diagnosed for so many years now, and actually we're worse now than what we were back then with diagnosis. So I think we do at some point have to, and that's not down to the medical professionals, that's down to people higher at making decisions. But I think we're going to lose so many incredible doctors if we carry on ignoring it, and it's kind of that vicious cycle that we need to really break. And again, that's why I'm a huge advocate of getting patients involved in boards with hospitals.
Yeah.
So like I do it for North Wales and the whole of Wales with their gynae teams, and kind of that feedback is absolutely vital from patients. But also as a patient, we need to understand the pressures that you're under, and but regardless of that, I think you can still show compassion wherever you are.
Oh, yeah.
So,
Agree.
could you give us a bit more of a rundown of what is the Menstrual Health Project?
Yeah.
What does it entail?
we know
do
what
you
it
do?
is,
What
but you
have
need to
done?
tell us.
Yeah, I need to tell.
We're advocates for the menstrual health.
Thank you. So Menstrual Health Project was just an idea me and Gabs had. So Gabs is my co-founder and one of my really good friends that we had around my kitchen table years ago, and we both advocated online for a long time, and we'd just had enough of the fact that the kind of charities out there at the time that had information, the information was either outdated or wasn't really easily accessible, or wasn't it was very kind of jargon heavy and wasn't easy for people to understand. So we had this idea initially of starting a community group, and we called it Menstrual Health Project, and we quickly were approached by our chair at the minute, Kate. So Kate will be stepping down soon, but Kate is the one who helped us become a charity, because she turned around to us and said, this needs to be a charity.
You got this, girls.
Yeah, and both me and Gabs were like, can we do this? Can we run a charity? And it was never on our cards to run a charity. It kind of just naturally it progressed into that. And what we stand for is basically kind of destigmatising menstrual health in all areas. So we really work closely with schools, trying to improve their menstrual health education, how they deliver it, how we don't segregate genders, where we have the conversation with all genders. I think it's vital that we do that. And that we need to understand that the youngest person now starting their periods is age 7 in the UK. Average age is 10, not 12, so we're getting younger. And we need to improve that education in primary schools as well, because like my daughter's 10 and she still hasn't had that information. She obviously has had it from me, so she knows about periods for a very long time.
She's teaching everyone at school.
She's teaching everyone
she's
else.
the teacher.
And yeah, so I think for us, we work very closely with schools to try and improve that. So whether we go in and we give presentations to teachers on how to deliver it to students, depending on if it's primary school, they tend to have a really good rapport with their students because they're younger. So we tend to then talk to the teachers on how to deliver it to the pupils, and having things like accessible period products in the toilets rather than having to go to ask in the office. Things like toilet passes, making sure that they're not having to ask permission to go to the toilet. That's a really big one for us, because whether it be about periods or not, it could be anything else. You know, there's young people with stomas and various different conditions that means that they need the toilet and quickly. So I think we're not supportive of the stopping them going to the toilet. I think it's yes, there's going to be an element of people taking the mick, because there always is in high schools and things like that.
Such as that.
But actually the majority are there to actually, they need that access, and there's a reason for that. And then high schools, we delivered basically a pilot of how we would want to deliver menstrual health education from the age of 8 all the way through to 18. So, and it would be building on different subjects. So you'd start really light with obviously high school, what a period is, what the menstrual cycle is, kind of tracking your cycle as you get a little bit older. Understanding hygiene is one of the biggest things we don't talk about. Still in schools, we're not talking about how to insert tampons, but yet we teach boys how to use condoms, but then girls are going to YouTube and TikTok for how to use use tampons. So then they're not getting the right education, because we're not talking about toxic shock syndrome and all the risks hygiene wise anyway. You'd be surprised the amount of people that go to social media now for their answers, and if anyone's been on TikTok, you know it's full of false information. Which is why that really kind of gave us the fight to create our toolkit. So we were the first ever charity to do the toolkits the way we've done them. And we first did the endometriosis one. Mainly it was kind of, Gabs always describes it as a love letter to our younger selves, because that's what we needed as teenagers, to kind of say, actually, no, your periods aren't normal, something's not okay. And then they're all checked by medical professionals. They go through a rigorous process. They take about a year to create. Yearly they're checked to be updated. We committed to that. So our medical advisory board's made up of specialist gynecologists in endometriosis and different conditions, to specialist women GPs, to specialist nurses, clinical psychologists, dietitians, physiotherapists.
Everyone.
We've got everyone who
We
multidisciplinary.
so we get it all checked.
Disciplinary.
It's so important for us, because again, it's not just one person who's going to have access to your care if you're going down that line. So our endometriosis diagnostic toolkit was our first one. Our second one was our teenage under 18s toolkit. So that is no jargon, really easily to read. It has kind of a glossary at the back to explain everything. We changed our period tracker in that one as it's still a period tracker, but it's more about emojis and how to track moods and how you feel, because obviously your emotionally things change absolutely frequently as you hit teenage years, or preteens, as I'm noticing with my daughter at the minute. And that was really important to us, and we've had incredible feedback there across the UK now, which is amazing. We get emails every single week asking them to be posted here, there and everywhere. And then our last one that we've just not long done last year was the complete guide to menstrual health. So that's a bit chunkier. It goes into a lot about different conditions, but also things like pelvic floor dysfunction. It goes into the gynae cancers. We talk about kind of the importance of cervical screening, what you can do to make yourself comfortable, and all the tips and tricks with screening to try and improve the screening rates across the UK. And we've just had amazing feedback. We've just 99.9%, I would say, is positive. You always get that 0.1%. But yeah, we're very, very proud of them. And for us, we then also go into workplaces to kind of improve their policies around women's health. You'd be surprised how many workplaces haven't heard of conditions like endometriosis. So it goes down as stomach pain, or it goes down as things like that. So one of them we did was DHL, which is really male dominated, and you could see at the beginning of the kind of conversation, because it was a mandatory that they had to attend it, and you could see at the start they were like, why are we here? Because they saw menstrual health project at the top. And then by the end their viewpoint completely changed, because they either had daughters, wives, sisters. I remember one of the men coming up to us saying, can I please take a toolkit for my teenage son, because he needs to know about this in case he has a partner later on in life, and different things like that. We've had single dads, like trying to navigate how to talk about periods. So yeah, it was to improve information, destigmatise the conversation. And then we also do a lot of work with kind of local government and UK government to try and, as best we can, put our voices forward of what's going on in the community at the minute. And, we've been part of the women's health strategy and being involved, and then personally I've worked with NICE on the new guidance for endometriosis. So yeah, we've done a lot in a short I travelled travelled the UK, and we were very lucky last year. We got to briefly speak at the UN headquarters in Geneva on women's health as well. So
As you do.
we were meant to go this year to have more of a segment, but surgery called and private life called. So
fair play.
yeah, we couldn't go, but we've had some amazing opportunities, and we've done incredible work, but we couldn't do it without the team that we've got, our trustees, our medical advisory board, our volunteers. You know, there's about a team of 23 of us.
It's amazing.
It's amazing.
A little well done to the team.
It's also incredible that you've done it alongside your journey as well, because you know the amount of time that you've had spare, I'm sure is little, and you've achieved so much with it. We will put a link to the Menstrual Health Project at the end of our episode. This is quite a difficult question. So if you had kind of one, or maybe we'll give you 2 or 3 key things that you wanted people to take home from these 2 episodes that we've done with you, people with or without endometriosis, what would they be?
That's really difficult.
It's a difficult one,
First, I would say to anyone listening is don't feel like you can't talk about these subjects. Talk about them openly, you know. I think we need to break down the stigma as much as we can about talking about women's health just in general. I think for far too long we've been in this put up and shut up kind of phase, and for me, I'm really, you know, really empowered to make sure that my daughter knows she can talk about these things, and if people squirm at them, then they've just not had the right education yet.
Exactly.
And
if they squirm at them, then you're doing the right thing by talking about it.
Exactly. I think it's just making sure that it becomes part of your normal conversation, you know, because there's always someone like myself who was in school all those years ago who was desperate for someone to say, actually, that's me, or, you know, I'm going through something similar, or, you know, so you can feel that you're heard or somebody understands you, because there's nothing worse than feeling alone and just feeling isolated. So definitely don't be afraid to talk about these subjects, especially publicly. I know that is a generational thing as well, that we've been silenced into thinking that we shouldn't talk about these subjects for certain reasons. But actually, you know, the more we talk about it, the more it'll normalise it for men as well. Like my husband always says, I wish we'd have been part of that conversation when we were in school, because he knows everything now. Like, he knows way more than I think a lot of people do. But you know, he had to learn along the way as well, because he didn't understand the gravity of what endometriosis could do, or also what the different kind of, you know, jargon meant. You know, things like urethra and, you know, ureters and kidney. You know, talking about it, he was like, so what connects to what? Yeah, like there was a lot of that. There was a lot going on. And 2, I would always say trust your body. If it's telling you something's wrong, something's wrong. And speak openly to your medical professional. Don't go in all guns blazing straight away. Like, don't feel like they're going to be against you, because you'd be surprised. There are so many people now, medical professionals, who are there to help. They just have, especially primary care, I feel like they've got such a short time frame that they have to kind of get to the bottom of what's going on. Don't be afraid of saying, could this be endometriosis, or could this be fibroids, or whatever it may be, because that might just click for that GP and go, actually, it could be, let's send you for this test or refer you on. I think I remember one of our consultants on our board saying the biggest help you can do to a medical professional is if you have done some research, don't be afraid to mention it and actually talk about it. So definitely do that. Make sure everything's put on your records, because you'd be surprised some things don't get put down. And thirdly, find your people. There's people out there who are there to support you. Like, that's how I started years ago on social media, just using it as a virtual diary. And part of it can bog you down, definitely. I always say stay away from Facebook groups. They can be quite negative. But there are people there that you'll connect with kind of socially. You might find somebody you work with when you're talking about it, but talking about it openly is the only way you will get through it. Don't kind of silence yourself and don't hold it in. And yeah, just try your best. That's all you can do.
That's great.
100%.
Thank you. I feel like that was amazing, and what we needed from that.
Exactly.
I feel like we've been around the houses, guys. Do you feel like we've asked all of the questions that we want of Anna on part 2?
Yeah,
Honestly,
I think we must.
I think that we've gone really nicely into depth into more than what we planned to, I think.
Yeah,
you know, 'cause
definitely.
there's so many different facets to your journey, but not just your journey as someone with endometriosis, also what you've done alongside that with the Menstrual Health Project, with all of the advocacy you've done. And I think anyone listening to this with endometriosis will be inspired and will really benefit from hearing your story, but also people who don't have endometriosis will gain a lot from hearing about
I think this
what you've been
episode
through.
is for anyone and everyone to listen to.
Definitely.
And definitely look at the Menstrual Health Project website, because that is
to hear all this
useful.
amazing stuff that you've done alongside going through everything that you've been through is just incredible.
Thank you.
Thanks for coming back.
Thank you.
Thank you so much for coming
so
back.
much. No, it's thank you for having me. I think the biggest thing for us is you've got to turn it into a positive. So the only way there was to do something about that, and that was MHP and talking about it as much as you can. And
we
Spread the word.
we applaud. Thank you.
No.
So a quick disclaimer, we only share our own opinions. They shouldn't be affiliated with where we work, and anything that we've discussed shouldn't be taken as personal medical advice.
Yeah, and if you've enjoyed this episode, if you feel as inspired as we do, please remember to leave us a review wherever you get your podcasts.
Might sound like a really small thing, but leaving us a 5-star review pushes the podcast out to as many people as possible, and we really want to just change the scope of misinformation and get really good quality information out there.
Please.
And we want this episode plus part 1 and the whole podcast to reach as many people as possible. So if you want to be a part of that ripple effect, then please hit the like button now.
And make sure you're following us on all of our platforms at Between Two Ovaries and engaging with our content. Thank you.
Bye.
That was so good.
Really good. I could listen to you all day.